Hello everyone, my name is Michael McBetty, and we'll be discussing how to perform abdominal paracentesis. I'd like to thank Dr. Sophia Jacob for her guidance during this presentation. In today's presentation, I'll discuss the indications and contraindications for performing a paracentesis. Next, I'll walk you through the steps, and we'll conclude by discussing complications as well as how to write the note. The indications for a diagnostic paracentesis include evaluation of new onset ascites, hospitalization, and clinical signs concerning for spontaneous bacterial peritonitis. A therapeutic paracentesis is helpful in the management of diuretic-resistant or tense ascites. The contraindications for a large volume paracentesis include DIC, fibrinolysis, massive ileus with bowel distension, overlying cellulitis, hypertension, acute kidney injury, and a late trimester pregnancy. It is important to remember that an elevated INR or thrombocytopenia are not contraindications. There are no absolute contraindications for a diagnostic paracentesis. Complications of a paracentesis may include acidic fluid leak, bleeding, infection, hypotension, renal dysfunction, and bowel perforation. Acidic fluid leak can be minimized by using the Z technique. If an acidic fluid leak does occur, applying sterile glue may stop the leak. In this video, I'll walk you through the steps of performing an abdominal paracentesis. First, the ascites is assessed using ultrasound. Consent is obtained, the necessary supplies are gathered, you and the patient are positioned comfortably, a timeout is performed, the skin is prepped, the skin is anesthetized, the needle is advanced until ascites is reached, and for a large volume paracentesis, additional steps, including the advancement of a catheter, sample collection, and connection to a drainage system are necessary. Lastly, the site is dressed. It is important to assess for a pocket prior to performing a paracentesis. The patient should be positioned in the supine position, turned towards the site of the paracentesis. The abdominal wall should be assessed for cellulitis, scar, and vasculature. Using the abdominal probe, a fluid pocket at least 2 cm in depth and all dimensions should be identified. Afterwards, the vascular probe should be used to assess the vasculature and measure skin depth. Here we can see a large bucket of ascites which appears hypoechoic on ultrasound. It is important to ensure adequate depth of ascites in all dimensions by moving and fanning the probe to ensure absence of bowel loops. Here the vasculature is visualized. It's helpful to use Doppler to ensure no vessels are in the anticipated trajectory. Once an optimal site is located, it should be marked using a sterile marker. Supplies for paracentesis include signed consent form, ultrasound, ultrasound gel, lab order slips and labels, a purple top EDTA tube, 2 blood culture bottles, chlorhexidine, alcohol wipes, sterile gloves, a 60 and a 10 cc syringe, sterile container, a 25 gauge needle and an 18 gauge needle, a blunt fill needle, 1% lidocaine without epinephrine, gauze and adhesive bandage, and for a large volume paracentesis, vacuum bottles, albumin, and dermabond are helpful. Lastly, in certain circumstances, it may be helpful to have sterile towels as well as a white top cup for cytology. Some commercially available kits contain all the necessary supplies to perform a paracentesis, such as demonstrated here. It's helpful to note that the sterile tubes in these containers can be used for cell count, chemistry, culture, and gram stain. The Caldwell cannula is found in some kits, such as the Quick Tap kit, can be used to help facilitate drainage of fluid in a large volume paracentesis. It's helpful to send acidic fluid for gram stain, culture, protein, and albumin. In certain circumstances, it may be helpful to have other tests, including lactate dehydrogenase, triglycerides, glucose, amylase, ADA, and alkaline phosphatase. It's important to remember that serum albumin protein and LDH may also be needed. Many institutions have established protocols to help with the paracentesis. At Yale New Haven Hospital, the bedside paracentesis pathway contains all the relevant information for performing this procedure. After performing a timeout, confirming the patient's information, procedure to be performed, the site of the procedure, and allergies, the skin should be prepped. The proceduralist should wash their hands, don mask and eye protection, and then sterile gloves. Here the sterile field is applied with a planned insertion site within the center of the opening. For a diagnostic paracentesis, it can be helpful to use sterile towels to get a sterile field. Once the sterile field has been created, it is important to prepare the rest of the supplies. The lidocaine container should be carefully opened and then the lidocaine drawn into the syringe. It is also helpful to place gauze on the sterile field for easier access during the procedure. Here, the catheter is prepared by placing the needle within the catheter sheath. Lidocaine should be injected first by making a small wheel at the site of insertion, and then entering perpendicular to the skin. It is important to always draw back before injecting to ensure the needle is not within a vessel. The needle is then advanced until the sensitive peritoneum is reached and anesthetized. For a large volume paracentesis, a small incision is made in the skin to allow the catheter to enter. The catheter should be inserted using a Z-line technique, in which the skin is pulled to the side prior to catheter insertion. The catheter is inserted near the tip while negative pressure is applied on the syringe. As the catheter is advanced to the calculated depth, acidic fluid is drawn into the syringe. At this point, the catheter should be advanced with one hand while keeping the needle steady. Once the catheter is in, the needle is withdrawn, and then a 60 cc syringe is connected to the catheter in order to collect the sample. The stopcock should be rotated away from the catheter and 60 cc of acidic fluid collected for studies. After the sample has been collected, the stopcock should be closed, and the drainage system tubing should be connected to the catheter to allow for drainage of more fluid. The catheter drainage system can be connected to the accompanying bag or to vacuum bottles as demonstrated here. Once the desired amount of fluid is removed or drainage has stopped, the catheter should be removed. As soon as the catheter is removed slowly, gauze should be applied over the site and a dressing applied. Remember to always safely dispose of your sharps as well as vacuum containers appropriately per institutional guidelines. Some helpful tips include minimizing the amount of moving parts, measuring the depth of the skin prior to starting, and some needles have a safety feature that decreases their true length. A patient with a skin depth of more than 2 centimeters may be helpful to use a longer needle, such as that in a lumbar puncture kit, in order to reach the peritoneal cavity. Remember to always notify the patient's nurse and write a procedure note documenting the procedure. I'd like to thank this patient for kindly volunteering to be recorded, and thank you all for listening.